Welcome to the Cleveland Clinic's Respiratory Virtual Grand Rounds. I'm Dr. Raed Dweik, Director of the CME Activity and Director of the Pulmonary Vascular Program at the Cleveland Clinic. These Grand Rounds are case-based presentations where I invite some of the leading authorities in the field of respiratory medicine to discuss an important topic that I believe is worthwhile to your practice in order to help you be more confident in approaching and managing your patients. For today's presentation, I have asked Dr. Omar Minai to provide you with an overview of the classification, workup, and treatment of pulmonary arterial hypertension. Dr. Minai is a member of the pulmonary hypertension team at the Cleveland Clinic. He obtained his medical degree from Aga Khan University in Karachi, Pakistan, and completed his residency in internal medicine at the University of Connecticut and his pulmonary critical care and sleep medicine training at the Cleveland Clinic. Dr. Minai is a fellow of the American College of Chest Physicians and a member of several professional associations, including the American Thoracic Society, Society of Critical Care Medicine, the Pulmonary Vascular Research Institute, and the Pulmonary Hypertension Association, where he also serves on the editorial advisory board of the Advances in PH journal. Dr. Minai speaks on the topic of pulmonary hypertension at national and international meetings and has co-directed the Pulmonary Hypertension Summit and the annual Pulmonary Hypertension Symposium at the Cleveland Clinic for the past 10 years. Dr. Minai's case-based presentation includes integrated audience response questions that are designed to help you test your knowledge as you follow along. Here's Dr. Minai.
I'm Dr. Omar Minai. Today I will be talking to you about classification, workup, and treatment of pulmonary arterial hypertension. Before we start the talk, I'm sure most of you are aware that the new guidelines for diagnosis and management of pulmonary arterial hypertension came out recently. I will incorporate those guidelines in this discussion today as appropriate. I'll start out by talking a little bit about definition and classification of pulmonary hypertension. We'll briefly touch on pathophysiology and then spend the bulk of the time talking about screening and diagnosis and management-related issues in pulmonary arterial hypertension. We will then talk briefly in the end about progression and survival and treatment goals in patients with pulmonary arterial hypertension. So let's start right off with definition and classification of pulmonary hypertension. As you are probably aware, the systemic circulation is a resistance circulation, whereas the pulmonary circulation is a capacitance circulation. Therefore, for the same amount of blood flow through these two circulations, the pressures are much higher on the systemic side and much lower on the pulmonary side. So the mean pulmonary arterial pressure is approximately 14 millimeters of mercury. Pulmonary hypertension is defined as a mean pulmonary arterial pressure of greater than or equal to 25 millimeters of mercury at rest. Pulmonary arterial hypertension adds the requirement for a pulmonary capillary wedge pressure of less than or equal to 15 millimeters of mercury and a pulmonary vascular resistance of more than 3 Wood units. These criteria have to be met in the absence of significant cardiac or pulmonary disease. We come to our first question: which of these patients has pulmonary arterial hypertension? A, 73-year-old male smoker with an FEV1 of 32% and a mean pressure of 27 with a normal cardiac output and wedge pressure. B, a 47-year-old female with a BMI of 36, hypertension and diabetes, normal RV, grade 3 diastolic dysfunction, and a mean pressure of 30 with a wedge of 18 and normal cardiac output. C, a 52-year-old male with a history of coronary artery disease and heart failure with an EF of 25% and mild RV dysfunction with a mean pressure of 32 and a wedge of 22 and a low cardiac output. D, a 45-year-old female whose mother died of heart failure at age 48 with shortness of breath, grade 1 LV diastolic dysfunction, RV dilation on Doppler echo, a mean pressure of 46 and a normal wedge pressure with a low cardiac output, and a VQ scan showing reduced perfusion in a mottled manner. And E, a 46-year-old male with progressive shortness of breath for 2 years with normal lung function tests, Doppler echo showing RV dilation, normal LV, an elevated RVSP, and a VQ showing several segmental mismatched perfusion defects. And the answer, of course, is D. Patient in choice A has WHO Group 3 lung disease-associated pulmonary hypertension. Choices B and C are both WHO Group 2, which is diastolic dysfunction and systolic heart failure associated pulmonary hypertension. Choice E is probably chronic thromboembolic pulmonary hypertension, whereas the patient in choice D probably has true pulmonary arterial hypertension, and the mottled appearance on VQ scan is what is classically described in these patients. So as we just discussed, pulmonary hypertension is classified into 5 groups. Pulmonary arterial hypertension is group 1, which includes idiopathic and heritable patients, some drug-induced patients, and then patients where there's pulmonary hypertension associated with connective tissue diseases, HIV, portal hypertension, congenital heart disease, or schistosomiasis. 1' is the pulmonary veno-occlusive disease or pulmonary capillary hemangiomatosis, and 1'2 is persistent pulmonary hypertension of the newborn. WHO Group 2 is pulmonary venous hypertension or patients with left ventricular or left-sided heart disease causing pulmonary hypertension. Group 3 pulmonary hypertension is pulmonary hypertension due to lung disease or hypoxia. Group 4 is chronic thromboembolic pulmonary hypertension. And Group 5 is pulmonary hypertension with unclear or multifactorial etiologies. Patients with the chronic hemolytic anemias, such as sickle cell disease, are included here, and patients with systemic disorders like sarcoid are also included here. The talk today will focus mainly on patients in Group 1, which is pulmonary arterial hypertension. The REVEAL registry is the largest U.S.-based registry of patients with pulmonary arterial hypertension. This registry showed that approximately 46% of patients in the registry had idiopathic type of pulmonary arterial hypertension, whereas about 51% had pulmonary arterial hypertension due to connective tissue disease or collagen vascular diseases and congenital heart diseases. These were the so-called associated forms of pulmonary arterial hypertension. So the bottom line messages about diagnosis and classification of pulmonary arterial hypertension and pulmonary hypertension is that all pulmonary hypertension is not pulmonary arterial hypertension, and all precapillary pulmonary hypertension is not pulmonary arterial hypertension. This distinction is important to make because Group 1 pulmonary hypertension patients, which is pulmonary arterial hypertension, is different than Group 2 and Group 3 because Group 3 and Group 2 pulmonary hypertension have different pathology compared to Group 1. They are more slowly progressive diseases, and Group 2 and Group 3 are unlikely to respond significant manner to pulmonary vasodilator therapy, which is the treatment of choice in patients with Group 1 pulmonary arterial hypertension. Let's touch briefly on pathophysiology of pulmonary arterial hypertension. From a simple standpoint, pulmonary arterial hypertension is essentially an imbalance with reduced vasodilation and growth inhibition and excessive amounts of vasoconstriction and growth promotion forces. This results in remodeling and restriction of the pulmonary vascular bed, causing pulmonary arterial hypertension. 3 pathways are felt to be most important, and that's what we'll discuss, mostly because those are the pathways where all the agents that are available to treat pulmonary arterial hypertension currently arise from. The first is the arachidonic acid pathway, where prostacyclin levels are reduced in pulmonary arterial hypertension patients, and therefore there is less vasodilation and less growth inhibition. The second pathway is the nitric oxide pathway, where nitric oxide levels and cyclic GMP levels and activity are reduced in pulmonary arterial hypertension patients, so there is less vasodilation and less growth inhibition. And the third is the endothelin pathway, where endothelin, which is a potent vasoconstrictor and growth promoter, is increased in these patients, and therefore these patients have excessive vasoconstriction and increased growth promotion. All these pathways result in an imbalance in favor of vasoconstriction and growth promotion, resulting in pulmonary hypertension. However, recent evidence has suggested that the pathophysiology is not quite as simple as that, and perivascular inflammation and metabolic plasticity, along with in situ thromboses, also play an extremely important role in the pathophysiology of patients with pulmonary arterial hypertension. So the bottom line message about the pathogenesis of PAH is that the pathogenesis is a complex mechanism involving not just pulmonary vasoconstriction, but cellular proliferation, inflammation, and coagulation and metabolic abnormalities as well. Let's start briefly and introduce our patient that we'll discuss along the way. Our patient is a 37-year-old white male who presents with shortness of breath, and he had episodes of dizziness and one episode of syncope, no other associated symptoms, no significant past medical history, and no signs of diseases or history of diseases that are felt to be associated with pulmonary arterial hypertension, and no family history of pulmonary hypertension, congenital heart disease, or sudden death. When he presented to the outside hospital, his echo was read as abnormal and the RVSP was read as 74. He was placed on calcium channel blocker therapy, diltiazem, at 120 milligrams 3 times a day, and warfarin and Lasix. Now let's talk about screening and diagnosis of pulmonary arterial hypertension. So we come to the second question: which of the following is true regarding screening and diagnosis of PAH? A, most patients with PAH have an obstructive or restrictive pulmonary function test abnormality. B, a VQ scan is not required to rule out chronic thromboembolic pulmonary hypertension if a previous CT pulmonary angiogram reported no pulmonary embolism. C, an echocardiogram showing normal LV function and RVSP 50 millimeters of mercury is diagnostic of PAH. D, a right heart cath is required in all patients suspected to have PAH prior to initiation of pulmonary vasodilator therapy. And E, there are no clear guidelines regarding screening for PAH in high-risk populations. Please answer now. And the answer, of course, is D. A right heart catheterization is required in all patients suspected to have PAH prior to initiation of pulmonary vasodilator therapy. Now, let's take each in turn. Most patients with PAH do not have an abnormality in their lung function. Only about 1/3 of patients with PAH will have mild pulmonary function abnormalities. So A is incorrect. A VQ scan is absolutely required, and a CT pulmonary angiogram is not adequate to rule out chronic thromboembolic pulmonary hypertension. An echo is the best screening test we have for pulmonary hypertension, but is not a diagnostic test. Therefore, an echo is never adequate by itself to make a diagnosis of pulmonary arterial hypertension. So C is incorrect. And there are absolutely clear guidelines regarding screening for PAH in high-risk populations, and we will come to them in just a second. So E is also incorrect. Now, diagnosis of pulmonary arterial hypertension is often delayed, and the NIH registry showed that it takes about 1.3 years from symptom onset in the patient to diagnosis of pulmonary arterial hypertension. And this was only marginally improved in the recent REVEAL registry to approximately 1.1 year time duration between symptom onset and diagnosis. This delay is largely because of the symptoms of pulmonary arterial hypertension being nonspecific. And there are several causes of these symptoms that are more common than pulmonary arterial hypertension. The REVEAL registry has shown us that most patients with pulmonary arterial hypertension, when they are diagnosed, are already in an advanced stage of disease, so that approximately 60% of patients with pulmonary arterial hypertension were diagnosed in World Health Organization function class 3 or 4. This data is even more stark among patients with collagen vascular disease-associated pulmonary arterial hypertension. This is a high-risk group, and you would expect that screening would help us make the diagnosis earlier. But in fact, more than 60% of these patients are also diagnosed in function class 3 or 4 in an advanced stage of disease. So why is that? Is it because we don't have adequate screening strategies, or screening does not work in this patient population? There is good data from Europe coming out recently that this is not true. In one European publication, without any screening strategy, most patients with CTD-associated pulmonary arterial hypertension were diagnosed in functional class 3 and only a minority in functional class 2. Whereas after a screening strategy was instituted in patients with connective tissue disease and scleroderma-associated pulmonary hypertension, far more patients were diagnosed in functional class 2 and a minority were diagnosed in functional class 3. So clearly, the institution of a screening strategy can help us make the diagnosis in these patients earlier. These are the current recommendations of screening strategies in various high-risk groups. The two most common of these are patients with systemic sclerosis, where yearly echoes along with lung function tests are recommended. And these have been recently detailed in the DETECT recommendations, which are at the bottom of this slide. And the second group is the congenital heart disease group, where an echo and right heart cath is recommended. And once again, these recommendations can be read in detail from the recent pulmonary hypertension guidelines that are detailed at the bottom of this slide. In terms of diagnosis of pulmonary arterial hypertension, there is a fairly complicated algorithm that all patients who are suspected to have pulmonary hypertension should go through, and this is this algorithm from the recent guidelines. However, from a simple standpoint, to me, number one, high-quality studies should be performed and should be interpreted by people who have expertise in interpreting these studies so that appropriate recommendations can be made. When evaluating a patient suspected to have pulmonary arterial hypertension, the first step is to rule out significant left heart disease and rule out significant parenchymal lung disease, which are groups 2 and group 3, respectively. Once again, this is because this form of pulmonary hypertension is much more slowly progressive, is a different disease, and does not seem to respond very well to pulmonary vasodilator therapy. Step 2 is to rule out chronic thromboembolic pulmonary hypertension, which is group 4, by doing a ventilation perfusion scan of the lungs. Once these diseases have been ruled out and patients don't have other etiologies that are suspicious for group 5, such as sarcoidosis or chronic hemolytic anemias, then you are left with patients in group 1, which is pulmonary arterial hypertension. Patients should undergo blood testing and other evaluation to figure out which type of pulmonary arterial hypertension this is. And then they should have right heart catheterization for an accurate assessment of hemodynamics, and they should be evaluated for their functional capacity either by a 6-minute walk test or by a cardiopulmonary exercise test. So back to our patient who was 37 years old when he was placed on a calcium channel blocker at baseline after an echo. When he came to see me finally, 4 months into his therapy, he had a blood pressure of 92/70. His JVD was elevated. He had a loud P2. He had bilateral edema, clear lungs. His 6-minute walk distance was only 896 feet, and he was requiring 1 liter of oxygen to maintain his saturation at about 93%. Usually the first screening test that patients with pulmonary hypertension or suspected pulmonary hypertension have is a Doppler echocardiogram. The important thing to remember is that the echocardiogram is the best screening test we have, but is not a diagnostic test. In addition to this, on echo, we have to make sure we look beyond the right ventricular systolic pressure at other things such as right ventricular enlargement, right atrial enlargement, straightening of the interventricular septum, loss of the inspiratory collapse of the inferior vena cava, the presence of a pericardial effusion, which is indicative of poor prognosis, and to look at RV function by factors such as the tricuspid annular plane systolic excursion, which is very well indicative of the presence or absence of RV dysfunction. In the case of our patient, the EKG showed right axis deviation and RA enlargement. Chest X-ray showed cardiomegaly with clear lung fees. A CT scan of the lungs showed no pleural disease or interstitial lung disease. A VQ scan was read as low probability and was later reviewed to show fairly normal ventilation and perfusion, and pulmonary function tests were normal. His echo showed an EF of 55% with a normal LV size and function. The RV was dilated with systolic function was severely decreased and the TAPC was 1.5. The right atrial cavity was minorly dilated, and the RV systolic pressure was 75 millimeters of mercury. So the next step in this patient is obviously right heart catheterization. Every patient who is suspected to have pulmonary arterial hypertension should be considered for pulmonary, before being considered for pulmonary vasodilator therapy, should have right heart catheterization. This is done to establish a diagnosis accurately, to assess disease severity, and to assess prognosis in the patient, to exclude congenital heart disease convincingly, to measure the wedge pressure or the LVEDP accurately, and to assess response to acute vasodilator therapy. In terms of our patient, the right atrial pressure was very elevated at 19. The mean pulmonary arterial pressure was 45 millimeters of mercury, very elevated. The wedge pressure was normal at 15, and the cardiac index was very low at 1.6. So the bottom line messages about diagnosis in pulmonary arterial hypertension is that there are clear screening guidelines that should be followed in high-risk populations for the early detection of pulmonary arterial hypertension. Diagnostic evaluation should include all pivotal tests. The most common etiology of pulmonary hypertension is heart disease, followed by lung disease. The ventilation perfusion scan should be performed in all patients to rule out chronic thromboembolic pulmonary hypertension, and a CT pulmonary angiogram is not an adequate test. Right heart catheterization should be performed in all patients being evaluated and considered for pulmonary vasodilator therapy. And inaccurate assessment of the wedge pressure is a very common source of error in assigning patients into the correct pulmonary hypertension groups. And the wedge pressure should be documented very accurately, or if it's felt to be inaccurate, the left ventricular end diastolic pressure should be measured. Now let's turn our attention to the management of pulmonary arterial hypertension. Before getting into the details of how to treat, it's important for us to set certain treatment goals. And in a progressive disease that ends in mortality in a high number of patients, an important goal should be to improve survival. And while we improve survival, we also want to do that with improving quality of life. Quality of life can be improved by improving exercise capacity as measured by the 6-minute walk distance or functional class, improvement in hemodynamics, and all of these things will prevent clinical worsening. Patients will be hospitalized less frequently, and hopefully they will die less. These goals can be best attained by a group effort between the patient's pulmonary hypertension specialist at the specialist center, as well as the physicians taking care of the patient locally, be they pulmonologist, cardiologist, or rheumatologist, as well as the patient's primary care physician. These people need to work together, keeping in mind clinical practice guidelines and clinical trial evidence to optimize the patient's care and hopefully improve outcomes in these patients. The most recent and updated treatment algorithm is presented here. It is recommended that certain general measures should be adopted in all patients. Supervised exercise training is recommended in patients, but patients are to avoid strenuous physical activity. So anything that causes chest discomfort or dizziness or excessive shortness of breath should be avoided. Patients should avoid pregnancy because it puts an undue pressure on the patient's pulmonary circulation and their heart. Patients should follow the usual health management guidelines in terms of vaccination and immunization. Diuretic therapy should be used as per the patient's clinical requirement and the expertise of the treating physician. And digoxin is also used at the patient's need and as per the experience of the treating physician. Two things require a little more attention. Number one is oxygen therapy. Oxygen can be used in these patients to prevent or reduce hypoxic vasoconstriction, which may have a role to play in these patients. It's important to remember that even though PAH patients may not require oxygen at rest, they may require oxygen supplementation during exercise or sleep and when they travel at altitude, including air travel. We usually aim for a saturation of approximately 89 to 90%. And it's important to remember that patients with pulmonary arterial hypertension who have congenital heart diseases will not correct their hypoxia because of their shunt. Anticoagulation is another issue that's important to consider. Anticoagulation is recommended in idiopathic pulmonary arterial hypertension, but this data is observational only. There are no randomized, controlled, prospective studies of anticoagulation in any form of pulmonary arterial hypertension. However, it is my practice to anticoagulate patients with pulmonary arterial hypertension who have idiopathic PAH or connective tissue disease-associated PAH or drug and toxin-induced or familial PAH, as well as those with congenital heart diseases. However, the firmest guidelines are for patients with idiopathic pulmonary arterial hypertension. The goal of INR should be between 1.5 to 2.5. We come to a third question. Which of the following is true about treatment of patients with PAH? A, all patients with PH on right heart catheterization should undergo vasoreactivity testing. B, most patients with PAH are expected to be vasoreactive if tested. C, only patients with demonstrated presence of vasoreactivity are candidates for CCB therapy. D, positive vasoreactivity is defined as a 20% decrease in mean PA pressure and PVR with a stable cardiac output and blood pressure. And E, patients without a positive response on vasoreactivity testing do not benefit from long-term vasodilator therapy. Please answer now. And the answer, of course, is C. Only patients with demonstrated presence of vasoreactivity by right heart catheterization using one of the approved agents, including inhaled nitric oxide, are candidates for CCB therapy. These are only approximately 5% of patients. Therefore, B is incorrect. Most patients do not demonstrate vasoreactivity and are not vasoreactive. Therefore, it's important that if you are considering the use of calcium channel blockers, that vasoreactivity tests should be performed, because CCB therapy is appropriate only for vasoreactive patients who are a small minority of all PAH patients. And even the 5% number of patients who are vasoreactive is among patients with idiopathic pulmonary arterial hypertension. Patients with connective tissue disease-associated pulmonary arterial hypertension, there are estimates suggest that only about 1 to 2% of patients may be vasoreactive, and there is certainly no long-term data about the use of calcium channel blockers or the benefit of calcium channel blockers among those patients. A is incorrect because all patients do not need to undergo vasoreactivity testing. Clearly, patients who are functional class 4, who have very advanced disease, or who are in overt right heart failure would not be treated with calcium channel blockers and therefore do not require vasoreactivity testing. D is incorrect because 20% decrease in mean PA pressure and PVR is the old definition of vasoreactivity, and patients without a positive vasoreactivity response absolutely benefit from long-term vasodilator therapy. In fact, they are the ones who are candidates for that therapy. They just should not be treated with calcium channel blockers. The new definition, or the currently accepted definition of a vasoreactivity, is a decrease in a mean PA pressure of more than 10 millimeters of mercury to a pressure of less than 40 millimeters of mercury with a stable cardiac output and blood pressure with acute vasodilator testing. These are the only patients who are candidates for calcium channel blockers. So back to our treatment algorithm. Once the general measures have been instituted, patients should be referred to an expert or someone who has experience in diagnosing and managing patients with pulmonary hypertension. These patients should undergo right heart catheterization and preferably should have acute vasoreactivity testing. If they are vasoreactive and they're function class 1 to 3, then they can be treated with calcium channel blockers. However, they should be followed closely because some of these patients may not have a sustained response. Those who do have a sustained response can be treated with calcium channel blockers alone. Among patients who are functional class 4 or patients who are syncopal or not vasoreactive, as well as patients who do not have a sustained response to calcium channel blockers, even though they were initially vasoreactive, all of these patients are appropriate candidates for pulmonary vasodilator therapy and will benefit from this therapy long term. Before determining what to do next, let's get back to the right heart catheterization of our patient. Remember, our patient is 37 years old, one episode of syncope, no obvious underlying causes of pulmonary arterial hypertension, TAPC of 1.5, and this is his right heart catheterization showing a mean RA pressure of 19, elevated pulmonary artery pressure, normal wedge pressure, low cardiac output and index, and a PVR of approximately 10 to 12. So the question is, what would be the next step? A, start parenteral vasodilator therapy and discontinue calcium channel blockers. B, continue calcium channel blocker therapy. C, start parenteral vasodilator therapy. D, start oral vasodilator therapy. And E, none of the above. Please answer now. The correct answer is A. The patients should be started on parenteral vasodilator therapy. He has several risk factors. He's had syncope. He has very low TAPC. He has a very poor 6-minute walk distance. He's already requiring oxygen. His RV is dilated on the echo, and his hemodynamics are very abnormal with a high PVR and a very low cardiac output and index with a very high right atrial pressure. So this patient is a good candidate for parenteral vasodilator therapy, and his calcium channel blockers should be stopped because that was started inappropriately. Number one, no vasoreactivity test was performed, and number two, he was functional class 4 to begin with since he was syncopal, and therefore that, and given his poor hemodynamics and functional capacity, he is not a good candidate for calcium channel blockers. All the other answers are incorrect because answer A is the correct choice. When determining initial choice of therapy, we have to take risk factors and patient's disease into account. Even though most pulmonary vasodilator therapies are approved by their patient's functional class 1, 2, 3, and 4, most of us think of patients in terms of low risk and high risk groups. Low risk meaning patients who have less advanced or early disease, that is less rapidly progressive, that has less evidence of right ventricular abnormality, and the patient has preserved functional capacity and better hemodynamics. Higher risk being patients who have more advanced disease or patients who have more rapidly progressive disease, who have more evidence of right ventricular failure, have worse hemodynamics, and have worse functional capacity. The idea being that low-risk patients can probably be initiated with oral medications to treat their pulmonary hypertension, and patients with higher risk category should be treated with parenteral medications and followed very closely. Notice that inhaled therapy is not first-line therapy in any patients with pulmonary arterial hypertension. When selecting initial therapy for patients, disease stage should be taken into consideration, as well as the risk of disease progression and the underlying disease etiology. On the other hand, patient considerations such as comorbidities, the route of administration, the cost of the drug, patient prevalence and patient preference, and patient's ability to handle the medication should also be taken into account. There are several medications that are approved for the treatment of pulmonary arterial hypertension. The idea is to use these medications to rebalance the disbalance that occurs. So reduce the vasoconstriction and growth and increase the vasodilation and inhibit growth. And this can be done. Prostacyclin levels are reduced in these patients, so we can supplement prostacyclin from the outside by giving prostacyclin analogs to cause more vasodilation and inhibit growth. We can block the effect of endothelin in these patients by giving endothelin receptor blockers to reduce vasoconstriction and reduce growth promotion. And we can give phosphodiesterase inhibitors or soluble guanylate cyclase stimulators or nitric oxide to increase nitric oxide and to prolong or promote cyclic GMP activity to produce vasodilation and to inhibit growth in these patients to rebalance this disbalance that causes pulmonary arterial hypertension. In all these medications, there are several pivotal trials among each category of drugs. The first is the prostacyclin analogs. I will not go into each trial in detail except to say that all these medications have been tried in short-term, blinded, prospective studies showing improvement in 6-minute walk distance, in functional capacity, in symptoms, as well as hemodynamics. Intravenous epoprostenol is the only form of prostanoid therapy that has been shown to improve survival in one of these studies. The endothelin receptor antagonists, again, bosentan and ambrisentan have both been tried in short-term trials, both showing improvement in walk distance, improvement in functional capacity, delay in clinical worsening, and some degree of improvement in hemodynamics, either measured by cath or by echo. The new kid on the block in ERAs is macitentan, which is approved at the 10 milligram once-a-day dose. This is a drug that was studied in a long-term study of 740 patients with a 10 milligram dose, delayed disease progression and reduced hospitalizations among patients with pulmonary arterial hypertension. About 60% of these patients were already on PDE5 inhibitor therapy at the time of enrollment. The other patients were drug naive. The third pathway was the phosphodiesterase, was the nitric oxide pathway where PDE5 inhibitors have been used for several years. Again, short-term studies showing improvement in walk distance, symptoms, as well as hemodynamics and quality of life in terms of tadalafil. More recently, Riociguat, which is a soluble guanylate cyclase stimulator, has been studied in these patients in a large 445 patients phase 3 trial showing an improvement in 6-minute walk distance. About 50% of these patients were on stable background therapy with ERAs in this study. Now, most of these studies have shown patients that have been placed on open-label long-term outcome studies, which typically in all these studies have shown approximately somewhat sustained improvement in 6-minute walk distance and fairly good long-term outcomes in terms of patients alive at 1 and 2 years out. However, these are open-label long-term studies. Now, single-agent therapies typically eventually fail because this is a progressive disease. While some patients continue to do well, most patients will require the addition of second or third therapies, and this is the so-called sequential combination therapy practice that we see in pulmonary arterial hypertension patients these days. However, there are several caveats in terms of this long-term combination therapy. Number one, there are no trial data that has studied the question of monotherapy versus upfront de novo combination therapy. One such trial is going on, but that is at least a year from completion. All currently reported trials featured add-on protocols. So this is the protocol of sequential combination therapy. And in this form of therapy, it's not clear how much individual agents add to the treatment success of the previous agent. And in addition, combination therapy trials have only a short-term component, typically with no long-term follow-up. There are several trials either recently completed or ongoing that are looking at the issue of combination therapy, and in the coming couple of years, we will have much more data to guide us in terms of which combinations might be better and whether upfront combination is better than sequential combination therapy or monotherapy. The poster child for combination therapy is the PACES study, where patients with epoprostenol, stable doses, were taken and randomized to either placebo or 80 milligrams 3 times a day of sildenafil. And what was seen was that the sildenafil combination epoprostenol group had improved 6-minute walk distance and had much lower clinical worsening rate compared to patients who were on epoprostenol alone. And therefore, this was a positive study showing that combination therapy has benefit over monotherapy. The Hanover group in Germany looked at some treatment goals that had previously been shown to be reflective of good outcomes in patients. A 6-minute walk distance to more than 380 meters, a peak VO2 of more than 10.4 ml, and a peak systolic pressure of more than 120 during exercise. And they sequentially treated patients starting from oral therapy to add-on therapies as long as the patients did not meet these goals as 3 to 6 month visits. And what they found with this goal-oriented therapy was that they could improve transplant-free survival and prostanoid-free survival, as well as overall survival in the goal-oriented treatment group, which is in yellow here, compared to their own historical controls, which is in blue here, as well as in the expected survival group based on the NIH registry equation developed in patients who were untreated back in the early to mid-'80s. More recently, a report from the REVEAL registry looked at patients who died and looked at the treatment at the time of death and found that somewhat disconcertingly, 35% of the patients were on monotherapy, about 8% of patients were on no therapy, and only about 43% of patients were being treated with parenteral prostanoid therapy, therefore making the case that we are underutilizing parenteral prostanoid therapy, which is life-saving therapy in these patients with pulmonary arterial hypertension. At the Cleveland Clinic, we have our pulmonary hypertension registry, so we looked at our own patients, and among patients where death was directly related to worsening pH, we also found that some patients had not been treated with parenteral prostanoid therapy before death, but there were valid reasons where these patients either had concomitant lung disease or were unable to handle the rigor required for parenteral therapy, or they refused parenteral therapy. And so there were valid reasons why in some patients parenteral therapy may not be initiated before death. However, most patients should be at least offered the option for parenteral therapy because parenteral therapy is likely to be more effective and life-saving therapy among declining patients with pulmonary arterial hypertension. Just as concerning in that report from the REVEAL registry, when they looked at patients who had declined from function class 2 or 3 to function class 4, in about 2/3 of those patients, the physicians who reported that decline did not add any additional therapy to the patient's care, which is probably inappropriate. And in only less than 20% of patients was parenteral prostanoid therapy initiated as a result of this deterioration, which is probably also inappropriate. Now, when single-agent therapy fails and then combination therapy is initiated and then combination therapy, despite this combination therapy or the institution of parenteral vasodilator therapy, patients still declining, then they are referred for lung transplantation. Regarding lung transplantation, early referral is better than late referral. Although drug therapy may delay transplantation, when a patient is function class 4, they probably should be referred for lung transplant evaluation. Patients who remain in function class 3 or progress to function class 3 on combination or parenteral therapy should be assessed for transplantation. Patients who have pulmonary veno-occlusive disease should be immediately referred for lung transplantation. And then if patients improve on therapy to function class 2, they probably can be removed from the lung transplant waiting list. So the bottom line messages about treatment of pulmonary arterial hypertension are that patients should be evaluated by physicians with expertise in treating pulmonary hypertension. Calcium channel blockers should only be used in vasoreactive patients. Choice of initial therapy depends upon disease stage, disease progression, patient preference, and physician experience. Inhaled medications are never first-line therapy in patients with PAH. Oral therapies are effective and may be the initial choice in low-risk patients. Parenteral therapies are life-saving and should be the initial choice in high-risk patients and those with disease progression despite oral medications. Pulmonary hypertension is a progressive disease and patients require close monitoring and follow-up with testing. These are not patients who can be followed up every 6 months or so. The patient should probably be seen every 2 to 3 months with appropriate testing, including 6-minute walk, a good clinical history and evaluation, perhaps a BNP, and maybe echo. Current practice is sequential combination therapy in those failing monotherapy, and the role of upfront combination therapy requires further study. Physicians should guard against the underutilization of life-saving parenteral prostacyclin therapy because these patients will suffer if they are not placed on these medications that may potentially be life-saving for these patients. Patients with advanced disease at diagnosis or those not responding to parenteral or combination therapy within 3 to 6 months should be referred for lung transplantation. A few words in the end about progression and survival. And we come to our last question. Which of the following is false regarding biomarkers and survival in PAH? A, right ventricular dysfunction is the predominant cause of hospitalization and mortality in PAH. B, simple measures of functional capacity, such as NYHA class and 6-minute walk distance, are extremely important predictors of long-term outcomes. C, baseline pulmonary hemodynamics have been consistently shown to be superior to functional parameters in predicting long-term outcomes in PAH. D, B-type natriuretic peptide is a useful and widely available biomarker that has value in PAH follow-up. And E, frequently hospitalized patients have worse outcomes compared to patients not requiring hospitalization for PAH worsening. Please answer now. And the answer is C. Baseline pulmonary hemodynamics have not been shown to consistently be superior to functional parameters in predicting long-term outcomes. These are complementary evaluations. Both have value. In fact, several long-term studies have shown functional parameters such as functional class and 6-minute walk at baseline to be superior to baseline hemodynamics. But they are felt to be complementary in terms of predicting long-term outcomes, so both should be assessed and not one or the other. Right ventricular dysfunction is the predominant cause of hospitalization. That is true. Measures of functional capacity are very important long-term outcome predictors. BNP is a useful test to have and is a good biomarker, and frequently hospitalized patients do have worse outcomes if they are hospitalized for worsening pulmonary hypertension. Pulmonary hypertension is a progressive disease, as we talked about earlier, and progresses through several stages with worsening symptoms, worsening pathology, and worsening hemodynamics with dilating right ventricle, which is more dysfunctional, dilating right atrium, lack of collapse of the inferior vena cava, bowing of the septum, and patients are often misdiagnosed for months or even years at a time. The pulmonary hemodynamics keep progressing over time. With rising pulmonary vascular resistance in green and the stable cardiac output, the PA pressure rises. Unfortunately, diagnosis is usually made at a time when cardiac output starts to decline. But because the PVR is rising, we are fooled into thinking that the disease is stable because the PA pressure is relatively stable. The patient is not stable. The patient is progressing and getting worse. The PVR is getting worse, the RA pressure is getting worse, and the cardiac output is declining. Untreated, the NIH registry showed that the patient has a median survival of approximately 2.5 to 3 years. More recently, the French have shown that we have improved outcomes in these patients by approximately 10 to 15% with the institution of chronic pulmonary vasodilator therapy. Several registries have predicted long-term outcomes in these patients fairly accurately with survival equations, and these equations, among these, the best known is the REVEAL registry equation, but once again, which is very accurate but fairly complicated. There are several relatively simple indicators of long-term outcome and good prognosis in these patients on therapy. If they are functional class 1 or 2, if they have a good 6-minute walk, a good heart rate recovery, they don't need oxygen when they walk, if they have normal hemodynamics, if they have a positive response to calcium channel blockers, or if they have a BNP that's less than 180. We have recently reported that a simple measure of measuring heart rate recovery after a 6-minute walk, if that is less than 16 beats at 1 minute, predicts very poor long-term outcomes in patients with idiopathic pulmonary arterial hypertension, and have found very similar data for clinical worsening as well as survival in connective tissue disease-associated pulmonary arterial hypertension. This is a simple, free biomarker that can be measured fairly accurately along with the 6-minute walk test. The reason many of these patients may not do well with vasodilator therapy is because there are other processes that are ongoing that are extremely important in disease pathogenesis, with vascular proliferation, remodeling, in situ thrombosis, and inflammation all playing a very important role. Therefore, there are several reasons for poor survival in PAH. If the diagnosis is delayed, if the therapy is delayed, if there is inadequate therapy. So we start therapy but are not aggressive enough in our therapy or don't escalate it early enough. Many of these patients may have comorbidities, and some of it may be that we don't have drugs that are as good as we need them to be, because most of these drugs are predominantly pulmonary vasodilators, and they may not address other pathophysiologic mechanisms adequately. The recent pulmonary hypertension guidelines have set certain goals of therapy that we should target for the future when treating patients with pulmonary hypertension. We should aim to make them functional class 1 or 2. We should aim for a near normal echo or on RV on echo, and as well as near normalization of hemodynamics on heart catheterization, an improvement in walk distance of approximately 400 to 440 meters, especially in younger people, cardiopulmonary exercise testing, and BNP that may be normal. These are all benchmark guidelines that we should strive for when treating patients with pulmonary arterial hypertension. So to conclude, I'm going to say that PAH is a progressive disease, but prognosis improves with survival, with therapy. Improvement in outcomes falls short of our goals, and there is room for improvement. Suspicion of disease and adherence to screening guidelines in patients with risk factors is essential. Patients declining on single-agent therapy can absolutely benefit from the institution of combination therapy. Parental prostanoid therapy is the most effective medical therapy and is often underutilized in patients with progressive disease. Future pulmonary hypertension therapies aimed at targeting mechanisms such as cell proliferation, growth, apoptosis, and angiogenesis are currently under study and hopefully will improve outcomes more in our patients long term. Thank you.
Thank you, Omar. In this presentation, Dr. Minai covered multiple aspects of pulmonary hypertension, including the definition, classification, screening, workup, and available treatment options. He discussed the important role of echocardiography as a screening tool and emphasized the crucial role of right heart catheterization in making a definitive diagnosis. He then drew a clear distinction regarding what constitutes pulmonary arterial hypertension, which was the focus of his presentation. Throughout his talk, Dr. Minai incorporated recommendations from the most recently published diagnosis and treatment guidelines, as well as insights from the U.S.-based REVEAL registry and our own large registry at the Cleveland Clinic. I hope that you found Dr. Minai's presentation on the classification, workup, and treatment of pulmonary hypertension to be a useful update on this topic, and that it will help you with the day-to-day management of these patients. Finally, on behalf of myself, Dr. Minai, the Respiratory Institute, and the Cleveland Clinic, I would like to thank you for listening to this Respiratory Virtual Grand Rounds presentation.